Professor Lee, there's one further article from the 1970s I want to ask you to look at. It's PRSE 0003622. And this is the Lancet, September 1978. It's a report by Professor Preston and others, percutaneous liver biopsy and chronic liver disease in haemophiliacs. And if we look at the summary, and this should come up on the screen in front of you, Professor Lee, the summary says, systematic screening of 47 haemophiliacs in Sheffield revealed abnormal liver function tests in 36, 77%, with a tendency for these abnormalities to persist. To assess the importance of these abnormalities, percutaneous liver biopsy was carried out on 8 symptom-free patients under Factor VIII cover. A wide spectrum of chronic liver disease was demonstrated, including chronic aggressive hepatitis and cirrhosis. The liver pathology bore no relation to clinical history or to biochemical findings. Hepatitis B virus markers were common, but evidence suggests that this was not the only factor contributing to the development of liver disease. The high incidence of chronic liver disease seems to be a recent development and is probably related to factor concentrate replacement therapy. And then if we go to the third page, please, Henry. Under the heading Discussion, we zoom in a little closer. We can see it starts by saying that 77% of our treated haemophiliacs had abnormal liver function tests, and a history of a hepatitis-like illness was elicited in 50%, and then this is contrasted with earlier reports. And then if we go to the next paragraph, please, Henry, we can see it talks about biopsies, and then halfway down that paragraph it says, we also found a wide spectrum of chronic liver disease, including benign self-limiting chronic hepatitis, potentially treatable chronic aggressive hepatitis, and established cirrhosis. All our patients were symptom-free at biopsy, and it was impossible to differentiate between the different forms of liver disease on the grounds of biochemical abnormalities. Since the patients undergoing biopsy had been arbitrarily selected, it's reasonable to conclude that a large proportion of haemophiliacs receiving treatment with Factor VIII have important chronic liver disease. And then one final paragraph, next column, please, Henry. Go up a bit. Picking it up 6 lines down into the first main paragraph, Professor Lee. In addition, non-A, non-B hepatitis may well be an important factor, and observations in 4 of our 8 patients support this possibility, and then that is developed in the rest of that paragraph. And then we have the conclusion that histological liver disease is common in haemophiliac patients, and then again it goes on to talk about assessment by use of biopsy. Now, I'm not at the moment asking you about the practicalities or indeed the risks of liver biopsies, which you've already alluded to and we may come back to. But just in terms of the importance here of the findings of evidence of chronic liver disease, would you agree that this was a significant paper?
This was a significant paper, but I think it's important that it's realised that there were other studies. I think the other thing I've had time to reflect on when I had the break is I don't think this is a memory test. And I am a great believer in looking at documentation. And if I'm allowed, could we look at what Benucci writes on this matter?
Is that the same document that we were looking at before?
Yes.
So, Henry, it is... I'll find it again. WITN 0644071.
I would... The next page, please. I'd point you to the second paragraph. As we've discussed, it talks about, unequivocal evidence of the existence of structural liver disease in people with haemophilia and elevated transaminases. We've talked about that. But I think what's important is the bottom of that paragraph where he talks about a prospective study was undertaken by me with the hepatologists Colombo and Risito in 10 haemophiliacs with non-A, non-B chronic hepatitis, followed up for more than 6 years. The study, published in 1982, demonstrated no case of progression towards cirrhosis or hepatocellular carcinoma. Then, so that was his experience. I'm not saying this was universal. What I'm trying to show is that different patients were showing different progression rates, and not everybody was showing any kind of abnormality. And then I think the other significant thing that he states here is the relatively benign picture of non-A, non-B hepatitis initially emerging from these studies was questioned by 3 subsequent studies published in 1985 and 86. So a large retrospective study of liver biopsies collected by Aladort provided histological change in 15% of cases, so 15% of the total. And it's worth noting that within that worldwide collection of data of liver biopsies, one of his patients had died of the liver biopsy. And then I think this is the study you're talking about, isn't it? I think.
No.
Well, this is from the same group. And an 8-year prospective study conducted in Sheffield, histological signs of cirrhosis were found in 9 of 79 haemophiliacs, 12%. I mean, what I'm trying to show you is that there was a realization this was a problem, but there was debate at that time as to how severe this problem was and what was happening. And some of the papers published who'd done biopsies showed abnormalities. Some of the studies did not show abnormalities. And of course, the other issue, which I think I took up with Professor Preston in the debate over doing liver biopsies, because it is relevant, is that liver biopsies were very often done on more severe patients. So it wasn't at all clear as to how many of the patients were progressing. There was no doubt there was some kind of problem. And some of the experience at this time, and you know, Minucci's study was showing that. What these people were looking at is, you know, when you treat a patient with clotting factor concentrate, you're doing it for a reason. You're doing it to stop severe bleeding. And what they were weighing up is how severe is this transaminitis or non-A, non-B hepatitis? We don't know. And is the risk of not treating them or them not receiving concentrate, is that risk worth taking? That was the debate. And I think the other important thing in this paper that he writes is on two pages, 2068, it's on the paper.
It's 2 pages further on, Henry.
And he writes, this is called the Fallacy of Retrospective Knowledge. And he sets out in the table...
Just a moment. I think it's at the bottom of the... Thank you.
No, yes, but I think we just need...
You were looking at your paper
No.
perhaps,
There's a table at the top.
I see.
Can we just see the table at the top first? He sets out in this table a very good chronological order of how knowledge developed, both for hepatitis and AIDS. And so now can we go back to the bottom, which and it's talking about the fallacy of retrospective knowledge. Table 1 summarizes the chronology of the development of knowledge about hepatitis and AIDS in hemophiliacs. To sum up, even though the problem of hepatitis was known since the 1970s, there was no reason to believe that this adverse effect of haemophilia care was heralding the much more ominous AIDS. On the whole, everybody was muddled in the period between the early 1980s and the first cases of people with haemophilia and AIDS were reported. Now, I know you're talking here, you've separated off hepatitis, but there is absolutely no doubt at that time that there was a debate going on about how severe these changes were. Was everybody going to get this? Was it fastly progressive? And that was being weighed about. It's all a balance of risk. It was being weighed up about whether treating the patient, it was important to treat the patient, to give effective treatment. I mean, some of the reasons, people would have died of bleeding if they hadn't had these concentrates. So it's a balance of risks.
Come back to balance of risks, Professor Lee, but first of all, Professor Minichi entitles this the fallacy of retrospective knowledge. He is, of course, writing retrospectively at this point.
Sorry, he's writing
He's
what?
writing retrospectively in this article. If we look at his table at the top of the page, and we just look at hepatitis, because we're going to come on to AIDS separately, we can see, for example, none of the materials which I've just referred you to are there set out in his chronology of the main events in hepatitis. He refers to some early reports, 70 to 72. 1975, he cites his own piece of work. 1977, he cites liver biopsy, and for the reasons you've explained, liver biopsies were not something that could be frequently undertaken. And then he goes on to desmopressin, DDAVP, and then to the 1980s. So it's not, by any stretch of the imagination, a comprehensive chronology of the developing knowledge of non-A, non-B hepatitis, is it?
I really find that very difficult, what you've just said. This man lived through treating his patients through all of that period, and there is absolutely no doubt around this time that there was a debate as to what transaminitis meant. There's no doubt that that it was clearly stated in some of these papers that this hepatitis occurred. But the debate was also about how serious the transaminitis was. Was it worth stopping the treatment because it was terrible, or was it more important to go on using the treatment? And, you know, as things transpired, the later information we had showed that actually, for many patients, it was a very, very slow progression. And indeed, for some patients, quite a few actually, they lived through an era where we had treatment for hepatitis, so it could be cleared. So are you saying that in this period, that treatment should have been stopped because they get hepatitis? And maybe they have the problem of bleeding?
Professor Lee,
these people... No, can I just finish? I'm sorry. But these people benefited from the clearing of their hepatitis in the end. And I just will emphasize again that in this time there was debate about the seriousness of the transaminitis. I don't think anybody doubted it was there. but there was debate about the progression and the seriousness. And I would say again, Preston's paper, where he biopsies, he worked alongside a very able hepatologist called Dr. David Trigger. It's more likely they were biopsying the patients who looked as if they were more badly affected.
Yes.
So you have a skewed vision.
You and Professor Preston, I think, have crossed swords, if I may put it that way, in relation to that issue in the past. And
I don't think it's a question of crossing swords.
Disagreed, perhaps.
I'm sorry. I don't like that. I am a physician. I care desperately about my patients. They're not my patients, it's the patients. And throughout my career, I have wanted to do the best for those patients. And for me, the best I can do for patients is based on evidence and also safety and efficacy. And I do not, and the reason you're using this term cross swords, which I don't really like, because it was just showing our experience and questioning whether it was right to risk death from a liver biopsy and provide cover to cover the liver biopsy. I don't think that's crossing swords. It's trying to fight for care and investigation of patients to be relevant.
Would you accept that you and Professor Preston disagreed about whether his was effectively a selection of the most serious cases?
I think what I would say is that I put into the public domain the experience we had had. And as a physician, the way I have approached looking after and caring for patients has been that I need to know what is going on, but I need to know in a way that is not risky for them. And what we're going to perhaps talk about it, I don't know, but what I wrote up in that letter was an experience. It wasn't when I was there that the person died of the liver biopsy. It was during the time that Dame Sheila Sherlock was investigating these patients with liver biopsy. But having had that experience, there was no way we were going to expose patients to the risk of death from bleeding. And I do not like the idea that you are suggesting that I cross swords with somebody. I'm a doctor, and we're all in the thing together. We're all trying to find out knowledge, to find out what is best for our patients. We're not fighting.
Professor Lee, let's leave aside the term I used.
Sorry?
Leave aside the term I used.
Thank you.
The question I was simply putting to you is, are you aware and do you accept that Professor Preston disagreed with your characterisation of his research? That's all.
I think I didn't disagree with the results he got. Not at all. Not at all. In fact, they were very helpful. What I did disagree with was the approach of doing unnecessary liver biopsies. And for the reasons I've said, there was a patient that died. But what I would also say is that as we went through the 90s, and then we had CT scans and imaging, the consultant hepatologists that I worked alongside were able to do what's called Trans-Jugular liver biopsies, where the needle went down through the vessel into the liver. And they could do that under an image. They can see where the needle goes. When you do a liver biopsy, I've never done a liver biopsy. When you do a liver biopsy, in the days that these were being done, the needle goes into the liver. The liver is an incredibly vascular organ. So you could hit a vessel. It's quite dangerous. And also, each one of those liver biopsies had to be covered with a large amount of concentrate. So that's another issue. That's probably a minor issue, because I think, you know, that shouldn't be an issue. But it's the safety issue. And I think it's terribly important that we're pursuing science here as applied to haemophilia care, which then makes the care of those patients good and safe. But you can't do anything unless you know what's going on.
Professor Lee, we may be slightly at cross purposes. I'm not seeking to challenge your view that liver biopsies could be dangerous, or your view that they are not something that should generally be undertaken. That's not the purpose of my questions. I'm looking simply at the question of what was known the second half of the 1970s and what was not known, the emerging picture in relation to non-A, non-B hepatitis. Professor Preston's work was a part of that picture, an important part of that picture. I'm not suggesting it was a complete part of the picture, and you pointed to some of the other studies here. Can I ask you to look at two descriptions of non-A, non-B hepatitis?
Well, before you do that,
yes.
Can I just ask a couple of questions about this paper by Bonucci in the 1990s? Could we go down to the bottom of the page, please, Henry? Under the fallacy of retrospective knowledge, the second sentence, to sum up. So what he appears to be saying, this sums up the fallacy of retrospective knowledge. Even though the problem of hepatitis was known since the 1970s, there was no reason to believe that this adverse effect of haemophilia care was heralding the much more ominous AIDS. And then on the whole, everybody was muddled in the period between the early 1980s. That muddling, as I read this, and please tell me if I'm reading it wrong, I read the muddling to be about AIDS and the link between hepatitis and AIDS. Because I think he's saying that hepatitis is one thing, put that on one side, AIDS is another. That's the way it seemed. Have I got it wrong?
Well, not really wrong, but what he's trying to say is that one of the big problems was that mostly, and this was knowledge that was gained later, the people who mostly who had big problems with liver disease actually had co-infection with HIV. And we now know that HIV was coming in 79. So I'm not saying all these studies, but some of the studies overlap that period. So what he's saying is that we had no reason to know that then. I don't know if that explains it or not.
Well, I'm not sure it does, because it's really a question of how one reads the words. But the second question I want to ask you, can we go back to the very first page of this article, please, Henry? Just something that caught my eye at the bottom of the page. It's the very bottom right-hand side, hepatitis, emergence of the hepatitis problem. And this is what Bonucci says through the 1970s, recognised the use of concentrates of coagulation factors made from plasma pooled from several thousands of blood donations was often associated with hepatitis. However, the first large study of liver function tests was published in 1975. Now that's Bonucci's own study, I think, because that's the reference. And our survey of 91 multi-transfused Italian hemophiliacs found that 45% of them had elevated serum transaminases. And although non-A, non-B hepatitis, can we turn over the page, was suspected to be responsible for transaminase abnormalities, a definite distinction between transfusion-associated hepatitis and transaminitis could not be made at that time. So our findings, the last sentence, our findings were subsequently confirmed and extended by a joint American-English study that demonstrated that transaminase abnormalities persisted, supporting the views that they were a hallmark of chronic viral hepatitis. Now, what he appears to be saying is that in his own work in 1975 demonstrated that there was a condition which was associated with factor concentrates made from large pools and the development of chronic viral hepatitis. It doesn't say how serious the chronic viral hepatitis was, but that's what he appears to be saying. And then what does it go on to say after that, Henry?
I think
unequivocal evidence. So he's saying that what he had suspected in 75 was unequivocally confirmed in 1977, and on it goes. Have I got that right? Is that the way it would read?
Yes, I think the other important thing in that paragraph is what I said earlier, the thing about the joint American-English study. This was Catherine Dormandy's study with Levine in Boston, and I said earlier about this that she had shown she'd been worried about transaminitis, and she compared her patients who were treated with cryoprecipitate with the American patients who'd been treated with concentrate, and transaminitis was in both, but there was more transaminitis in the American patients. So this was a piece of information that was in circulation. The other thing that's not actually written here, but I can tell you that there was a view held by some people that transaminitis may be accentuated by metallic things in the fractionation process. So what I'm trying to do, it's quite clear that there are descriptions of non-A, non-B hepatitis, not really defined as non-A, non-B, but going on. But the extent of this problem and the rate of progression and the seriousness of it was not clear. There was evidences in both directions, and it was that kind of information that was informing the way people or haemophilia treaters were treating.
Dr. Kernoff, in April of 1979, perhaps we'll look at this, Henry, it's BART 0002487. We go to the second page, please, Henry. You'll see there, it's a letter to Dr. Colvin, 27th of April 1979. We go to the paragraph numbered 2 under the heading Types of Therapeutic Material Available. And we'll go halfway down the paragraph. He's talking about commercial versus NHS concentrates. I don't need to ask you about that, at least not at this stage. And then he says the clinical reason for preferring NHS is the growing awareness of the probability that commercial concentrates have a higher risk of transmitting non-A, non-B hepatitis than NHS material. And then this is the sentence, Professor Lee. This is a serious disease with long-term consequences. I can take you to a reference the following month by Dr. Kernoff and Dr. Colvin, which talked about it as being serious with long-term sequelae and that the acute disease may sometimes be fatal. Would you agree with that characterisation? As at 1979, recognising there's still much to learn, it was known that this was a serious disease with long-term consequences.
Shall we use the word believed?
It was believed.
Yeah, can we begin at the beginning of that paragraph? The paragraph you just had, it's disappeared, hasn't it?
That's the paragraph. Types of therapeutic material available.
Saying that he wrote, the clinical reason is the growing awareness of the probability that commercial concentrates have a higher risk of transmitting non-A, non-B hepatitis than NHS material. Dr. Kernoff wrote that. It later transpired that is not true. And we're going to go and discuss that paper. But that came after that. So what I'm saying here, this is 1979, that even Dr. Kernoff clearly moved his view.
That wasn't, with respect, the question I was putting Professor Lee, which is, do you agree with Dr. Kernoff's characterisation as at 1979 that non-A, non-B hepatitis is a serious disease with long-term consequences? Was that a fair way of describing non-A, non-B in 79?
I think all I would say about that sentence, and this is written in 1979 by Dr. Peter Kernoff, okay, is that he writes as far as is known. And I think that is the qualification, as far as is known. And as we know, subsequent work showed...
I think the as far as it's known is dealing with its prevalence rather than its the long-term consequences.
No,
Just read it through. As far as is known, is at present much less common in the UK than in the USA, etc.
Yes, but okay. As far as is known, what I would say to that is it is a qualification. This is written in 1979, and if Peter had been, Dr. Kernoff had been alive in 2000 or 1994, he would have realised that actually there were some patients where the progression was very slow. Sadly, it was mostly the patients who had co-infection with HIV who progressed very rapidly. And, you know, we cared for those patients. And because all the clotting factors are made in the liver, it was very difficult. So I suppose what I'm trying to say is this is written in 1979, and Dr. Kernoff is aware of all these publications that you've shown, and he's balancing those publications up, and he's saying that it's a disease with long-term consequences. Of course, that's 79. You know, the long-term consequences for many patients didn't come until 2000. So that's what I'm trying to explain. Is that helpful?
Yes, but thank you very much.
Would you accept, in light of the material that we've looked at, indeed, and any other material that you're aware of from the second half of the 1970s, that it should have been appreciated by haematologists by the end of the 1970s at least, that non-A, non-B hepatitis was a clinically significant condition which carried a significant risk of causing liver disease?
No.
Why?
Because they weren't aware of that.
Well, Dr. Kernoff is saying it in terms. It's a serious disease with long-term consequences.
Yes, you asked me about all haematologists, didn't you? What was your question?
I'm asking you whether you would accept that, in general, haematologists should have known by the end of the 1970s that non-A, non-B hepatitis was a clinically significant condition which carried a significant risk of causing liver disease.
I suppose what I would say in answer to that is, in an ideal world, they should have known. But what I would say is that they did not know. I don't think any of us really knew for certain what was going on. I mean, that was why this study was being done, to understand it. So I think the idea that, you know, everything was understood by the end of the 1970s is wrong. There was all sorts of emerging knowledge coming out, and in parallel with that, there was treatment, remarkable treatment, and that's what people were weighing up, and they were one of the reasons for this study, this retrospective study that Dr. Kernoff wanted to be looked into for the information to be assembled and published, was to find out more about what is happening, what is going on. And of course, we're going to talk about it, I know, but the most important thing that study showed, and the knowledge up to that date had been completely wrong on it, was that whether the concentrate was made from blood donors in America or anywhere, or the UK, everybody got non-A, non-B hepatitis on their first exposure. And that none of that knowledge was available in the late 1970s. That emerged and began to be presented at clinical meetings, I suppose, from 1983 onwards. But what was known, you've shown it, was the Krask paper, and the knowledge was building up.
But Professor Lee, you used the term "for certain," things weren't known for certain.
Yes.
Professor Minucci used the term "unequivocal" in the paper that you've referred us to. Finding certainty, finding unequivocal evidence, may be something that might take many years of research and study. Clinicians will rarely have evidence of certain outcomes. They have to look at the risks. Would you agree?
Yeah, and I think, yes, and I think what is important when you're considering risk, the only risk that you are considering or you're throwing at me is the risk of this emerging picture of transaminitis, non-A, non-B hepatitis. Haemophilia treaters at that time, and indeed now, also have the risk to think about what happens if I don't give this patient treatment? What happens if this patient isn't having regular home treatment at home, so that when he develops a knee bleed at home, he can treat himself immediately, so that knee in future is not going to be a target joint and he becomes crippled, is a word that I don't like using, disabled. And I think always in this risk, and it goes for the whole of medicine, you are balancing risk. What were haemophilia physicians trying to do? They were treating people who had an inherited bleeding disorder. And they had to balance up, what is the greater risk? That I risk this person being at home and getting a cerebral hemorrhage? Or, I'm sorry to labour this point, but it really is important. And I think it's important. You've got this document somewhere. I've got a number. It's to try and convey what haemophilia is like untreated, and it is relevant. We are now in 2020, and what I want you to put up on the screen, if I'm allowed, is it's witness number 644-002/002.
So could you tell me what the
title of it is? It's from the textbook of haemophilia. It's a historical introduction that I wrote. Can you find it?
Unless it's exhibited to the long statement that you prepared for today, then it's not something that I can
all right.
put up
Well,
now.
am I allowed to read from it and provide this for you afterwards? I think it's probably in one of my Rule 9.
It's fine for you to read from it. We will have it, but we don't have it in the room electronically to display.
Would you forgive me if I won't read too much. What I was going to say was, this is 2020, and this is a publication that came in 1937 from America. And it was...
Is it the Birch paper?
Sorry?
Is it the Birch paper?
Yes.
Yes.
Yes. And so it was 113 people with haemophilia in 1937. And she, actually it's a he with a strange spelling, reviewed the causes of death from bleeding. And just to give you an example, 15 out of these people died from circumcision. 6 died from epistaxis. 7 from central nervous bleeding. And what's even more awful was that most of these people died before the age of 15 years. I think only 8 survived beyond 40. And what you're balancing is always risk of bleeding. I think we must not forget that people bleed. And it's often forgotten now because, fortunately, we now have recombinant products and our little boys can be treated with prophylaxis. And indeed now there's even gene therapy. So nobody ever sees bleed. And of course cerebral bleeding was the most devastating thing of all. So that's what I'm trying to convey.
1937 was not 1979, and the choice was not necessarily one of, in every case, treatment with concentrates or no treatment. Amongst other things, cryoprecipitate was available, and for non-severe haemophiliacs, DDAVP.
Yes, let's go back to cryoprecipitate. We know then that the incidence of hepatitis in blood transfusion was 1 in 300. This was done from post-transfusion studies. If you treat somebody with cryoprecipitate, you very quickly accrue a large number of treatments. And indeed, the paper that you have here from the lady who was a carrier of haemophilia, women who are a carrier of haemophilia, sometimes they have quite a low level of factor VIII. And she had an operation on her knee and was given cryoprecipitate. I think I need to get the paper, but she, I think in the end, had about 300 units of cryoprecipitate. She developed fulminant hepatitis C. She was in intensive care and nearly died. That was from cryoprecipitate. And that lady went on with long-term hepatitis C, and indeed in the end, she and her son both had type 1 hepatitis. Of course, her son had severe haemophilia. And they both cleared it with treatment, with interferon later on. So the idea that you could go and treat everybody with cryoprecipitate and it was safe and effective because people had a transaminitis or a non-A, non-B hepatitis for which we did not know the progression or the seriousness was really not a correct idea. Furthermore, I followed your questioning of Dr. Brian Colvin. And following that question, I went back to Catherine Dormandy's original papers, and I think it was the one in 1974, which shows in great detail what was needed to train people and to make cryoprecipitate. You're suggesting, I think, that in the late 1970s, that this concentrate is stopped being used, and we start going back to cryoprecipitate. Well, for a start off, if people are treating at home, they haven't got deep freezers anymore. In the hospital, and the blood transfusion service is not geared up to making this anymore. That's just a provision thing. But the most important thing probably, and you know there are many people in this room who were in receipt of concentrates, the convenience for the patients of these concentrates was extraordinary, because it was, you know, injecting, I don't know, 20 mils into your arm, having a little bottle that you shake up, that you can take when you go in your car somewhere, or you even go abroad, or you go to work. The patients wanted it. You know, and the other thing that we haven't talked about at all, I mean, we have kind of talked about it. I discussed with you how bovine factor VIII was developed, and how in Oxford they were therefore able to take people's teeth out. As things moved on, operations could be done for these patients. You know, people with haemophilia are no different to any of us. They can get appendicitis. They can get things that you need to do an acute operation on. And having these concentrates absolutely transformed things, because you could do that now. So I hope that explains things, and why it would not be sensible or even practicable to go on back to using cryoprecipitate. It was not a safe product.
It was a safer product than factor concentrates, whether NHS or commercial, was it not?
Well, it depends how you define safer.
In terms of risks of transmitting hepatitis, to start with. In
terms of transmitting hepatitis, if once you've got over 300 units, it's almost inevitable you're going to get it. But, you know, if you're treating a patient who has bleeding, what is the greater risk? Do you want somebody with, say, a cerebral hemorrhage to die because, you know, they've been treated with ineffective cryoprecipitate that hasn't brought the level up? And, you know, if you're operating on somebody, it's very difficult to plan how many units of cryoprecipitate you want when you can't even know what's in the bag. It's an extraordinary idea. And I think you have to balance the risks. And all you... I don't want to be aggressive, but all that is being seemingly considered at the moment is the risk of non-A, non-B hepatitis, which at the time there was very limited information. We didn't have, the virus wasn't identified until 1989, so we didn't have a test. You're suggesting that it was important to avoid that risk, and then you expose the patient with the haemophilia to a much bigger risk. Because if you use the concentrate, you know what's in the bottle. You can precisely dose it. And it's just a whole safer procedure. And I think from a quality of life perspective, it would also be an issue for the individuals with haemophilia.
Do you agree or accept that patients with haemophilia or other bleeding disorders who are going to be treated potentially with concentrates should be told that non-A, non-B hepatitis was a risk of their treatment and that it was a serious disease with long-term consequences, to quote Dr. Kerner?
I think at the time that you're talking about this, I fortunately, maybe for me, I wasn't in the position of talking people through their treatment. I've explained that what I was doing was following up information that had been acquired from that treatment. What I do know is that patients, when the knowledge evolved, was that patients would be told there was a possibility of this transaminitis or hepatitis, but the treater, or Peter, I suppose, at that stage, would have said, we don't know what the long-term consequences of this was. And I think I would just go back also to the point that for most people, it was an asymptomatic disorder. So it wasn't an issue, you know. Their priority was to be treated. But I think it probably, I don't know, because I wasn't Dr. Peter Kernoff in that period. I was, at that time, or certainly in the 1980s, when I was doing this research, I was looking at data. I wasn't the person who was administering the treatment.
The question I asked Professor Lee, and I'm not sure that you've quite answered it, is not what, as a matter of fact, patients were told at the Royal Free. Do you accept, you're free to disagree, do you accept that by the late 1970s or early 1980s, patients had a right to know, should have been told, that the treatment they were being offered carried a risk of non-A, non-B hepatitis, and that whilst much was still unknown, non-A, non-B hepatitis was a serious condition with long-term consequences?
I don't agree with that. And, you know, I'm trying to remember back 37 years, basically. You've quoted the papers, and what you've quoted is certainly true. But there was also a great unknown. So I don't agree with the totality of what you said there.
Do you disagree with my characterisation of the condition, or are you disagreeing with the suggestion that patients should have been given that information?
I don't disagree with patients being given information. I think all patients should be given information, and that's all the way certainly I've practiced. But it's very difficult giving information when the information itself is being debated and it is not entirely clear what is happening.
So, and this is a hypothetical question because I understand that you were not at the Royal Free at this time. But bearing in mind Dr. Kernoff's own characterisation of the condition as a serious disease with long-term consequences, is that a piece of information which, in your view, should have been given to patients at that time?
Well, I go back to what I said earlier. It was the knowledge at the time he qualified it. So I don't know. I wasn't in the position of giving the information at that time to the patient. I don't know what he told the patient. But when he qualified that, as far as is known, I'm sure he probably would have told the patient, this is a problem. That was his way. He told patients things. So I don't. But I think it is inappropriate to ask me what Dr. Peter Kernoff would have told patients.
That's not the question, Professor Lee.
What is the question?
The question, I'll say it again, the question is, do you consider, as at 1979 or 1980, that patients should have been told that their treatment carried with it a risk of developing non-A, non-B hepatitis, which was believed to be a serious condition with long-term consequences?
Can I answer that question? It's very difficult for me to say what consultants delivering care at that time should have said. maybe I can say I never treated one of those patients first time, ever, then.
In 1979?
No. I wasn't there.
Yes, I know. I'm trying to understand the point you're making, Professor Lee.
I didn't treat any patient there until 1987. Okay? So I've forgotten what the question is. I'm terribly sorry.
It's the hypothetical question.
Yes. Well, what I think I would say is that I can't project what I would have said then, but what I can project is what I would have said when I was in the position that, if I was in that position, in fact I wasn't in that position, of giving people untreated concentrate before 1985, and I'm sure that what I would have said is that there may be a problem, but we don't know what it means.
And is this your evidence in relation to what, as a matter of fact, the position was at the Royal Free, 1983?
No, it's not a matter of fact, because I don't know what Dr. Kernoff said to patients, and I wasn't in the position to actually give treatment then. I think,
Professor Lee, I think if you let me ask the question, you'll understand I wasn't suggesting what you think I may have been suggesting. As I understand your evidence so far, you're saying, as a matter of fact, you don't know what was or wasn't said to patients about non-A, non-B hepatitis.
Yes, that's right.
Is that not something that you ever discussed with Dr. Kernoff, given that you were researching the incidence of liver abnormalities in these patients?
Can I remind you again that the study I was looking at, the information, the retrospective information I was looking at, I started looking at the end of January 1983, by which time all the patients have been treated. There was still patients who were being followed up.
So is the answer to my question that you didn't have any discussions with Dr. Kernoff about the information that was provided to patients at that time?
No. My job was to try and find out more information.
As far as you know from your time at the Royal Free in 1983 and 1984, or indeed anything that you may have learnt subsequently about that time when you took up your consultant post there, were any changes made to treatment policies or practices in response to the risk of non-A, non-B hepatitis?
Which period are you talking about?
The first half of the 80s, but in particular 83, 84.
No, I wasn't in the position to... That wasn't my role, and it wasn't in my knowledge. And by the time I was in a position that I was a consultant in 1987, the concentrates were all heated. So the practices were never part of my job.
If we could just look at your evidence to the Lindsay inquiry, LIND 0000326. If we could turn, please, to page 15. So the very bottom of that page, you can see you were asked about what the practice was in 1983, and then you talked there about a very strict policy about using DDAVP for those with mild disease. And then if we go over the page, you say at the top of the page, for those who had severe haemophilia A, there was not any positive stopping of treatment, and people went on having both National Health Service and commercial concentrate. Now, the context of that question may have been the response to the developing knowledge of AIDS, but is it right to read that as being practices in relation to the treatment of patients at the Royal Free didn't change in 1983 and 84. That's how I'd read it.
I don't know about change. This evidence that I gave to the Lindsay inquiry 20 years ago was cross-checked with the people who were still, who had been working at the Royal Free at that time, and the records.
So, as you previously indicated, this is
I think
the most reliable evidence you can give on those questions.
This is very reliable evidence, what I said here. And, you know, I would remind you again that you're asking me questions in my memory about things that happened in 1983, which is 37 years ago. And what I would say about this evidence is that it is much more reliable. I'm then the director and professor of haemophilia at the Royal Free, and more importantly, I have the experience and I'm able to find or cross-check the record of what was happening. But at the time that I was doing the research, or looking at the information from the patient notes and trying to work out what had happened when these people had their first treatment with concentrate, these decisions, and if there were changes, they weren't my remit. All I can do is provide the evidence that was available. And I think it's very difficult for me, you know, Peter's dead and ceased working in 1991. It's quite difficult for me to know what rules and changes and things he made. I don't know.
So I note the time. I'm going to move on to the next topic of questioning to HIV and AIDS.
Well, let's give the professor the opportunity to break now till tomorrow, if you'd rather.
I would prefer that. I'm exhausted.
Well, I thought you might say that. So.
Thank you very much.
It's been one of those days, I think. But shall we meet together then at 10 o'clock tomorrow? 10 o'clock tomorrow morning. The rules that I mentioned to you apply overnight as they do at any break.
So I can't talk to my husband tonight.
Well, you can talk to him. I wouldn't ever want to stop that. But not about your evidence, either what you have said or what you may yet say.